So today, Amber, Candace, Courtney, and myself, Craig, are going to be addressing the challenges that refugees face accessing healthcare and things that we can do to help reduce these disparities and challenges.
So on this slide, we really want to define refugee and asylum seeker. So technically, any person who is fleeing persecution, conflict, violence, and human rights violations are considered migrants. Specifically with disparities in healthcare for refugees, it's important to define that an asylum seeker is an individual seeking host governmental protection, and then a refugee is an asylum seeker who's then been granted governmental protection. So they are legally, certifiably a refugee and entitled to those rights that come with it. So seeking asylum is a human right under international law since 1951. Since 1975, the U.S. has admitted over 3 million refugees and asylees. These people who come here are unable to return home due to fear of persecution and violence in their home country. So these reasons, while they're fleeing their home country, they are afraid and unable to return due to those outstanding issues that are in existence. And with this population, with their inability to return home, it has a huge impact on their health. So these individuals, these patients, carry a much higher disease burden because of the journey that they're on and the safety related to that. So the predominant healthcare disparities that the refugee population faces include financial affordability of healthcare services, health literacy, perception of quality of care, medical mistrust, cultural and religious barriers, transportation, use of social services, and immigration status. So barriers to healthcare refugees, there are many. So I listed off the ones on the previous slide, and now I'm just going to go through and go into greater detail. So financial affordability of healthcare service is a concern for Americans and even more so for refugees. They have difficulty getting access to insurance. It's expensive. It's difficult to navigate. Public assistance is difficult to obtain. The different communities that these refugees need in order to help them with these processes are non-existent. Health literacy is a huge barrier for refugees because on top of an existing language barrier, it is very hard for refugees to assimilate to an American protocols and way of life. So the ability to obtain, read, understand, and use healthcare information is severely hurting. So next we have understanding the healthcare system. So this is just the ability for refugees to navigate healthcare systems and understand our delivery model. How is the patient experience going? What's the patient's expectation versus reality? And understanding of the wait times for services here. Even something as small as that could be hugely uncomfortable and difficult and hard for refugees to navigate by themselves. Next, our disparity is medical mistrust. So this is discrimination and stereotyping based on race and ethnicity by caregivers. This is not being taken seriously. The refugees or the patients not being taken seriously because of this mistrust that's been developed. Transportation is a major disparity for refugees. There's physical barriers to receiving care. They physically cannot get a car to take them to these appointments, which are potentially very far away. And then the social support networks. We need engagement for refugees and people who are not from the U.S. to be engaged outside of the healthcare network. Immigration status is a huge barrier for refugees seeking healthcare. If you're an asylee, you don't even have the correct certification to even be in this country or even be able to get some of these healthcare services. So citizenship status is a huge barrier because of this very scary and formal assimilation processes. Our next slide are challenges contributing to healthcare disparities. So we discussed in detail these different disparities, but these challenges further enhance those disparities. So language barriers. There's changes in education received due to cultural barriers that restrict ability to deliver education appropriately. Like for example, sexual education for patients with stomas. So being unable to appropriately educate patients on their care because of a language barrier or a cultural barrier that's preventing appropriate learning. Transportation is a huge challenge, which is also a disparity. Patients are unable to get to these locations for health services because they are so far away. There's unequal treatment on public transit. There's fear of being approached by xenophobics on public transport. So it's not even the inability to obtain a car. It's then the assumption based on what you look like or what you're wearing or the language you speak being demoted to that lesser than status. Housing is another challenge for refugees in this patient population. There's illegal settlements, settlement housing, government housing, poor neighborhoods. These are the areas that refugees are kind of pushed into. They're overcrowded, unsanitary, and have very poor hygiene, which then contributes to infection, disease, all of these aspects that then complicate refugee healthcare. Employment is a huge challenge as well. There's lack of basic resources, access to proper foods. There's susceptibility to violence, mistreatment, harassment, threats, blackmail, exploitation, violence. These people come from a country fleeing fear and terror and death, and they come here and are exploited because of their language barrier or their desperation for employment. And then, of course, racial discrimination. There's refugees feel a less sense of belonging, lower levels of trust, reduced sense of control, less hope among migrants because of this racial discrimination that they face when they leave their home countries.
Being a refugee in a foreign country comes with a list of several challenges, one of which is the ability to obtain adequate and equitable health care. Many refugees' perception of the effectiveness of healthcare is already predetermined by their origin country. That, combined with a lack of understanding of cultural practices by healthcare providers, leads to a decrease in the quality of care. One nurse stated that due to barriers, a warm relationship is unfortunately not established. The way healthcare providers are able to communicate with refugees also greatly affects the perception of care as well as the compliance of the patient. Barriers in communication have been shown to have harmful health outcomes, decreased compliance, and delays from seeking care. One nurse stated, "If I am explaining nutrition education to Turkish-speaking patients using 100 words, we try to explain it to a refugee patient using more spot-on words, limiting it to 20 words." Despite having to use less words, communicating with patients that speak other languages cause an increase in workload, and nurses must allocate more time for these patients. Some refugees have also experienced racism when speaking with providers. One patient even recalled their interpreter later telling them that the doctor had said, "Oh, from Sudan? Oh, Sudanese, those are the worst people." To ensure that refugees receive and perceive great care, nurses should utilize the Campina-Bacot model of cultural competence and perform a cultural assessment on every client. Doing this would allow the nurse to learn more about the patient's beliefs, values, and practices and create a sense of trust between the provider and the patient. By completing this cultural assessment, it will allow the nurse to assess any health literacy issues that may arise. In the article by Ho and others, they mention that healthcare professionals and others should seek to understand how social determinants of health and their interactions will affect the access to healthcare for refugees, but also allow for equitable care over time. Cultural competency training is quickly becoming more necessary for all healthcare providers. According to Ho and others, this training will inform and orient healthcare professionals to the perspectives and needs of patients from backgrounds other than their own, while also providing actionable tools to more conscientiously interact with these less familiar patient populations. One training program that this article recommends is the Morehouse School of Medicine's Crash Course. Another resource that hospitals and other healthcare organizations should use during every interaction is interpretation services that are knowledgeable about the topics being discussed. There are several companies available 24/7 for interpretation via telephone that would allow for clear communication between provider and patient. Utilizing these resources would help to decrease fear and increase trust, allowing for greater care and better health outcomes.
According to the Refugee Act of 1980, we provide a permanent and systematic procedure for the admission of refugees of special humanitarian concerns to the United States, and also provides a comprehensive and uniform provision for the effective resettlement and absorption of those refugees who are admitted. This act also directs the director to provide English language training to such refugees receiving cash assistance. However, the cessation of refugee medical assistance after 8 months, plus government financial support ending at the same time, makes a transition very difficult for refugees, according to Zaydan, an article written in 2019. Furthermore, according to NASA, limited English language proficiency was the best predictor of poverty amongst surveyed refugees. This article calls for one step further in anticipation of refugees coming into the United States, which is training in English while they are awaiting entrance into the country. Policymakers should consider extending refugee medical assistance beyond those first 8 months as an additional strategy to improve access to health insurance and enable stable access to care. From a societal or structural perspective, and specifically economic, understanding the economic difficulties of refugees is key to providing interventions and opening up access to better health care. So as stated on the previous slide, refugee populations have government aid up until approximately 8 months. After this, they are expected to fill out appropriate paperwork, obtain employment with insurance offerings, and navigate the system alone. Unfortunately, due to the complexity of our system and lacking English skills, many are left in a state of confusion. So addressing availability of publicly funded healthcare insurance like Medicare and Medicaid, charity care, or other financing options, and then expanded healthcare access, this was viewed favorably in addition to other policies which enable care before payment. In terms of political issues, according to a recent Pew Research study, Americans, up to 72%, say taking in civilian refugees from countries where people are trying to escape violence and war would be a very or somewhat important goal for immigration policy in the United States. Overall, nurses can impact refugee health by utilizing social determinants of health, screenings, and advocating for the availability of those in the patient's native language while they're making that transition.
So in our final slide, we are going to be looking at evidence-based nursing interventions. So one of the first things to consider is that this population group has been through a very traumatic experiences. So establishing a therapeutic relationship with them, giving them some psychoeducation, stress reduction training, and helping them increase the self-awareness and acceptance of these experiences that they have gone through is going to serve this population in assimilating into their new culture. It's also going to be very helpful for us to establish those and connect them with those partnerships between governments and community providers. Of course, we want to give them linguistically and culturally adapted disease prevention, education, and then also through training programs for healthcare professionals in delivering care better suited to this population. Finally, as always, nurses, we must be aware of our own biases. We want to always use a medical interpreter with this patient population. That is their legal right. And then we also want to know our rights and the rights of our patient when it comes to dealing with immigration customs enforcement and customs and border protection. So there is no right on our part to disclose our patient information or immigration status. Refugees are protected by HIPAA laws, and we cannot give any legal advice to patients, but we can provide them with resources, but it is out of our scope to give legal advice.